So when we look at the melanomas and what biomarkers are present, we still have about a 30% proportion of the population where there is really no clear biomarker identified that can lend itself to developing a drug. This is unfortunate because for those patients, there really is not much other available than dacarbazine and Yervoy now. Also, I like to say that even though we have now these subpopulations based on V600 BRAF, this again is not a complete homogeneous population either. It's enriched, but it's not a black and white thing. So there are patients that respond much stronger and patients that have less of a response. So clearly there is further fractionation will happen, and that's why I said that the future I do see is a more niched approach to therapy. The other thing I would expect to see is that we will have a much more rational approach to combine a Zelboraf with another drug. We start calling these now companion therapeutics. And we're seeing signals emerge that lead to that. In the old days, everything was combined, what could have been combined, but there was very little logic and science behind it. We see that changing. We have already very beautiful examples in some of the BRAF-driven tumors where the most appropriate companion therapeutic is basically already on the market and should be tested. So this is a change there as well. It will be much more rational, and again, it leads to better development, faster timelines to bring new products and benefit to patients into the clinic faster. But it requires, I think, also in the industry, a rethinking that had consequences in organizational forms. A patient population consisting of 2,000 patients doesn't require a 20,000 people sales force, for example, I believe. And so we will see dramatic changes in the oncology business as a result of the science driving, looking for more niche opportunities, being better through the use of companion diagnostic approaches.